You will start question.
Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today, great honor. You all know Professor Tarek Mahdy. So it is really great honor for myself to have such a prestigious figure and interview such a great person. So definite, if every time we will talk about metabolic surgery, so we cannot forget Professor Tarek Mahdy, because his role, his contribution, especially for awareness and technical points that he's following today, it is a great opportunity for all of us to know more about metabolic surgery in low BMI patients. Sir, so much thanks to accept our invitation. Sir, over to you.
Thank you, Dr. Amran, for a very nice, kind invitation to me, to give me this opportunity to be with you and your audience and to discuss together about metabolic surgery in low body mass index. I think nowadays we can change the term of bariatric surgery to metabolic surgery, because the problem almost always you are going to treat the metabolic syndrome, not to treat the obesity alone. And you know, in WHO nowadays, since 2011, defines the obesity and the metabolic syndrome as a disease. So when you are going to treat the metabolic syndrome, you must be alert. What is the benefit to treat the metabolic syndrome? All of us who know the metabolic syndrome is consists of at least of two of them, for obesity, class 1, 2, 3, super morbid obese, and at the same time, hyperlipidemia and hypertension, diabetes, and sleep apnea. And all of this can be treated by metabolic surgery. So when we are going to discuss clearly about the metabolic surgery, we are not to go to decrease only the amount of food and the amount of fat, but you are going to change the gastrointestinal hormone, and you make the balance between the upper and lower gastrointestinal hormone. This is the cornerstone of the metabolic surgery. For this reason, we have a lot nowadays in the market, and all are active. And thanks God, we have a lot in our hands. We have a lot of tools in our hand to treat our patient individually, because you can't have in your hands a golden operation. We'll never have this definition till now, but we have a lot. We can select the proper one for our patient. We make full study, and the preoperative preparation is very important for our patient. When anyone asks me, how can you select your operation and which body mass index can you select? All of us, we know at least for one disease as diabetes is usually ranging from 30 to 35 body mass index. For this reason, you can't exclude all of this patient. I know the recommendation to do for morbid obesity above 40 and patient with one comorbidity between 35 and 40, and from 30 to 35 in uncontrolled diabetes. But nowadays, and all of my colleagues, not me alone, we can going for metabolic surgery for a patient from 30 to 40 and defined as low body mass index. And for me, nowadays, I didn't accept any patient come to me just to lose of weight. He must come to treat the disease, treat the obesity and diabetes and hypertension and hyperlipidemia. Because believe me, if you select your patient only to weight loss, the compliance of patients, the patient come to you to do operation to eat it freely. And this will lead to weight regain after 1.5 years or 2 years. For this reason, we must be alert about to select our patient with low body mass index who will benefit from metabolic surgery. First, we are going to the pre-op. Pre-op is very important because you select our patient and select also which type of operation you will use it. For this reason, all of my patients, I must exclude any, especially the Cushing syndrome and the hypothyroidism and the reflux esophagitis or hiatus hernia. Because if the patient have reflux esophagitis grade C or D or hiatus hernia more than 4 centimeter, it is prohibited to do for him sleeve gastrectomy. You must go to bipartition or for bypass operation. This is the first one. Also, you can tell your patient about the percent of resolution of diabetes. This is very important. You can tell your patient by very simple tests. If you make some tests, especially C-peptide, if the C-peptide more than 3, you can tell your patient that you're 100% have resolution of diabetes. If you have from 1 to 3, you can tell your patient you are going for complete resolution of diabetes around 70%. Less than 1% usually is around 20 to 22%. Also, the duration of diabetes is very important, especially sleeve gastrectomy patient. If the patient have duration of diabetes less than 5 years and he didn't have any reflux or hiatus hernia more than 4 centimeter, sleeve gastrectomy is suitable for him. But if you have diabetes more than 5 years and you have reflux or hiatus hernia, you must go to bipartition or gastric bypass. This is the ideal selection for your patient.
Sir, so much thanks. So we are also interested to hear about your journey of metabolic surgery, especially when you think we must do something those patients who are low BMI but with diabetes. So what was your initiative? What was your inspiration? We are also interested to hear about this.
Yeah, if you look, Dr. Amran, about the normal distribution curve for this of patients, the majority of the patient with diabetes is between 30 and 40. Yani it is, if you look for all incident all over the world, you will find that the patient with body mass index ranging from 30 to 40 have diabetes. So you can exclude all of this patient because the body mass index is 32 or 33, and you have tool in your hand to complete resolution of diabetes in this patient. So nowadays, if you have patient with diabetes and with low body mass index ranging from 30 to 40, it is easy to do it. We start to do it bipartition in this patient, especially from 30 to 40, and we are surprising with the results. The resolution of diabetes is up to 92%. It is near from scapular operation, but with less nutritional deficiency.
Yeah.
So nowadays, the metabolic surgery, it is the ideal treatment of type 2 diabetes, especially in a patient with low body mass index.
Sir, you have highlighted just now so far your preparation of patient. So need C-peptide. One of your criteria is C-peptide. So is this C-peptide is in fasting or stimulated? Or you also measure the serum insulin, and also you rule out LADA or any autoimmune impact of such like islet cell antibody or GAD65. What is your protocol?
Yeah, usually we are going to see peptide for fasting one. This will help us to know what is the amount of islet cell. At the same time, correlate with C-peptide, it is duration of diabetes. This is very important because we can divide our patient for the patient with diabetes less than 5 years and between 5 years and 10 years and more than 10 years. And we notice, especially in all study, that the most effective operations for a patient with diabetes more than 10 years is duodenal switch and SASI and transition bipartition operation. It is most powerful operation as a scapular operation, duodenal switch and SASI bypass in a patient with diabetes more than 10 years, because all of this operation are working directly in the gastrointestinal hormone. It is not to divert, it is not to decrease the amount of the food, it is playing the hormones. You make the balance between the upper gastrointestinal and lower gastrointestinal hormones.
Yeah, of course. Sir, so much thanks. So, and again, I will repeat this question regarding which patient you must rule out autoimmune disease. So maybe there is LADA, or maybe there is also antibody. So are you check all of your patients, or no? You have specific one. Yes, this patient may be LADA, and maybe after surgery we will not achieve that results. Yes, C peptide is high. We will see C peptide is 1.5, C peptide is 1.9. But you think, no, if I rule out this autoimmune, so have you any such criteria?
No, tell us when you are classified the type 1 and type 2 diabetes. You know, type 1 diabetes is autoimmune disease. And the problem in type 1, it is the antibody against islet cell. For this reason, usually the insulin is amount is decreasing, which is reflected on C-peptide. And sometimes in patients type, sometimes 90% of type 1 diabetes, the C-peptide is around zero.
Yeah.
For this reason, but some patient also in type 1 diabetes have the C-peptide around 0.1, 0.2, because, in type 1 diabetes, it is still the pancreas secrete small amount of insulin, which reflects in C-peptide. But if the patient have C-peptide more than 1 or more than 300%, it is not type 1 diabetes, because there is the insulin. Because, in type 1, 2 diabetes, the problem is different. The problem is not in insulin, but the sensitivity of insulin, the sensitivity of tissue to uptake glucose due to expression of insulin receptors. So this is a different pathway. For this reason, when we are going to make balance between the gastrointestinal hormones, the upper and lower, this will improve the insulin resistant and more expression of insulin receptors, the tissue, especially in the liver and in the muscle. For this reason, the C-peptide is a cornerstone for metabolic surgery, and also correlate with the duration of diabetes. This will reflect the amount, the mass of islet cell, because long-standing type 2 diabetes lead to burning of the islet cell, which going to insulin dependent after that. And also, we must know the most powerful operation, especially in scubolari operation, and some cases for duodenal switch after 10 years, due to continuous stimulation of the pancreas to secrete insulin, the patient have recurrence of diabetes and become insulin dependent diabetes, not type 2 diabetes.
Yeah, so much thanks. Sir, you have mentioned so regarding bipartition. Now your preference is bipartition or SASI?
Yes, as bipartition is a new tool in the market nowadays, we have another tool in your hand. You can select for your patient, but according to the GCI, you must give all options for your patient with advantage and disadvantage of operation. And your patient, you must select the operation. Don't select for your patient. You give your patient full data, full honest advantage and disadvantage of all your operation. And after that, let your patient to select. This will make difference in different culture, because in certain city, some people are going to select bipartition. And nowadays, the era of mini gastric bypass, so all of patients nowadays asking for mini gastric bypass. But when we have a lot of patients nowadays with results of bipartition, especially SASI bypass, a lot of patients nowadays come to asking to do SASI bypass, because when we are going to internet and to see the mechanism of SASI bypass and no diversion at all and have the same results as bypass. So a lot of patients prefer bipartition nowadays. I know the research about bipartition still in child period, but we encourage a lot of surgeons to do and to publish their experience and research. We have a lot of comparison between SASI bypass and sleeve and mini gastric bypass and Roux-en-Y gastric bypass and the new edition of Roux-en-Y gastric bypass with long BBL. And nowadays the internet a lot of study, but still in the child period, we encourage a lot to do, and we need the experience. We need a different results because if you have a lot of research about one operation in different countries, this will help you to know this is good operation or not. So this is very important to encourage. I think in Latin America nowadays, a lot of surgeons do it. In Asia nowadays, in Africa, in Egypt, in Tunisia, in Morocco, Algeria, even in African countries, and in Europe nowadays, we have 3 centers in Germany nowadays starting to do SASI bypass since 4 years, and in Italy, Portugal, and Norway, and starting in England now, and Turkey, many centers in Turkey nowadays. But in India, I think, and in China starting to do it. I have 2 or 3 meetings with a lot of surgeons start to do bipartition nowadays. So I think we are growing. Still, we need a lot of research about it, and at the same time, it is very important to us to know what is the ideal. In 2019, Dr. Fobi and the Mahendra in India have standardization for all bariatric procedures, and nowadays we have standardization of our technique in SASI bypass. I hope all of surgeons become adherent to this technique because, surgeon almost always likes to put his print in the surgery. Some surgeon decrease limb from 3 meter to 1.5 meter. Some surgeon we going to do the anastomosis. I will present now what is the mistake in SASI bypass. This will help us also. So please, if you like to do SASI bypass, you must be adherent to standardized technique, which is published also by Dr. Fobi in 2019 for all bariatric procedures. Because if you change any step in SASI bypass, you will convert it to diverting operation, and you will lose the benefit of the bipartition.
Sir, so much. Sir, can you share? Are you interested to share your video, any video, or your technique? Is it possible?
Yes, possible, for sure.
Sir, still, because when we talk about SASI, no doubt, so Tarek Mahdy will be at top. So always when we think, yes, SASI, so Professor Tarek Mahdy. So in my opinion, this is a great opportunity for all of us to hear from someone who is pioneer of this technique, who is one of the pioneer of this technique. We are interested to hear, sir.
I will start first by the video for SASI. Then after that, I will describe why we have discrepancy in result, because I saw many surgeons, especially in Egypt, it is completely different operation from SASI bypass and name as SASI bypass. For this reason, I will tell you, because I revise a lot of movie from Egypt and Saudi Arabia about patient have some problems, and I revise the movie of operation and I discover a lot of mistakes in it. For this reason, I will display first the operation. Then after that, I will display the mistakes when you are going to do the operation. So let me start from first from I will tell you first here to know this is widespread uh, will come now.
Yeah.
This is widespread nowadays. If you look here, we have widespread for the operation of cystic diabetes all over the world. Uh, uh, so some center have bad results, especially in Egypt. We have two center have the good result with cystic bypass because they are adherent to the standard technique, but in a lot of center have bad results because nobody are adherent to the standard. Each surgeon has a print of himself to the operation, so you convert it to another operation. Usually, we have a bad result in failure to resolve diabetes, hypoalbuminemia, severe anemia, edema lower limb, and liver insult, and even liver cell failure. I saw more than three patients with liver cell failure after cystic bypass. And when I revised these cases, I discovered that the surgeon brings the loop 1.5 centimeter only from the ileocecal valve and make gastroileal anastomosis with diameter of the gastroileal anastomosis 5 centimeter. You can imagine
Yeah.
5 centimeter gastroileal, so complete diversion of the foot, and 1.5 centimeter, only use 1.5 centimeter from the ileocecal valve. This is not a cystic bypass at all.
Yeah.
This is another operation. This is coronary operation. So the patient have liver cell failure. So if you look here, what is the metabolic surgery? If you are hunger, you have increased ghrelin hormone, decreased GLP-1, BWY, and X18, and after that, fast gastric empty, leading to the food to become and go down to the ileum, leading to intestinal satiety, decreased ghrelin, GLP-1, BWY increase, which make slow gastric emptying, but still we eating because the gastric satiety is dependent on the gluttony. So some of our patients told me I have satiety, but still I'm going to eat more and more because this depends on the size of the stomach. The gluttony is dependent on the size of the stomach. So first there is intestinal satiety, and last there is gastric satiety, and at the end the full satiety. So what is the aim of any operation? To bring the intestinal satiety and the gastric satiety at the same time. For this reason, we make small stomach. This will make gastric satiety, and intestinal satiety, we push some food direct to the ileum and to the duodenum. This will make balance between the hormones secreted in the duodenum and to the ileum, GLP-1, BWY. At the same time, we have a small stomach, so we cancel the gluttony. So at the same time, we have the satiety intestinal and the gastric satiety at the same time. So what is the cornerstone of cystic bypass? Ileal sleep, idle sleep, sorry, wide incisura, and complete excision of the fundus. This is the idle sleep. If you ask any surgeon, what's the idle sleep? You tell me complete excision of the fundus and wide incisura. And anastomosis to the ileum, not to the jejunum, because the cornerstone of hypertension and the cornerstone of metabolic surgery is to push food direct to the ileum to induce the secretion of GLP-1 BWY from the start. But if you are push the food to the jejunum, will take time when we are going to the ileum to start the intestinal satiety. Last, third one, to do your anastomosis with the anterior wall of the stomach. This is very important also because if you are going, as in many gastric bypass, to do the anastomosis with the posterior wall of the stomach, this means you make your anastomosis with gravity. This means that all of the food will going to your anastomosis. But if you are going to do your anastomosis with the anterior, this again is gravity, and you must know your anastomosis in the antrum, and the antrum has the muscle 6 centimeters from the ileocecal valve, and the diameter of the gastroileal anastomosis is less than 3 centimeters. Because if you are going to make your anastomosis more than 3 centimeters, you will make a lot of food. We need just small amount of undigested food to pass food to the ileum. And the last one, which is very, very important, because I saw a lot of patients with torsion. And you remember there is a case from Italy. Sanjay presented it in IBC about the patient have repeated vomiting because he don't alert about the isoperistalsis and the antiperistalsis. You must put because you are going to count from the ileocecal valve, not from the trans ligament as many gastric bypass. So you must be alert to put your ileum in the isoperistalsis, because if you put it in the antiperistalsis, the ileum will make torsion and the patient have repeated vomiting, because you will close the two-way, one from the duodenum and from the your anastomosis. So if you look here, this is must be have the idle one, idle sleeve gastrectomy, and the second you must identify the ileocecal valve. And from my experience, because the counting is very important, the length of the ileum is very important, and you know, if you repeat your counting, you will find another length. For this reason, you would highlight in your grasper for 10 centimeter and count from the mesenteric border of the ileum without any stretching of the ileum. This is very important. Second one, please don't count from the trans ligament, because this is wrong. This will convert to another operation, because the operation, the mechanism of operation, the coronary source operation to push undigested food to the ileum, not to the jejunum. Also, if you look here, Cheney have a good study about the length of intestine. Usually, the average length is the jejunum is 280 centimeter and the ileum 420 centimeter. So, in primary SASI, not as a revisional surgery, you can start from 3 meters from the ileocecal valve. You are in ileum. If you increase to 3.5, you are still in ileum. Even if you are going to 4 centimeters from the ileocecal, you are still in the ileum. So your range between 3 and 4, it's not a big difference, because the aim is metabolic. You need to push the undigested food to the ileum. The ileum here, the average is 4 meters and 20 centimeters. So usually we are recommend 3 to 3.5 from the ileocecal valve. But if you are going less than 3 centimeters, you have hypoproteinemia and you have iron deficiency anemia. And proper measurement of proper measuring. So you can highlight in your grasper. This is very important. And you see here the anastomosis in the posterior, and this another mistake. Your anastomosis must be in anterior wall of the stomach here, and the length must be less than 3 centimeters, 3 centimeters, or less than 3 centimeters. Other factor on the length of the ileum less than 2.5. This will mean your patient are going to liver sulfura. Believe me. Anastomosis just near to pylorus. No, we have our anastomosis is 6 centimeters from the pylorus. Some surgeons are going to the body of the stomach to do the anastomosis. If you make the anastomosis with the body, this means complete diversion, because the body will going direct to the ileum. But in the antrum contracted, so controlling the amount of the food which is going to the ileum. Antiperistalsis, this is a big mistake, because your patient have torsion at all, almost always. Always the post-operative care and poor dietitian rules is help to a more complication. So This is the standardization of bariatric in 2019 in India by Dr. Fobi. This is the standardization of the primary recessive bypass. The distance of sleeve transection away from the gastroesophageal junction 2 centimeter, 3 centimeters wide of the sleeve, distant from the pylorus is 6 centimeter, the height of the gastroileal anastomosis 3 centimeter or less, length of gastroileal limb from the ileocecal valve is 3 centimeter, not less than 3 centimeter, and the volume of sleeve is around 150 to 175 cc. This is the ideal operation when we are going. This is the French position, the surgeon between the leg, the same trocars as in sleeve gastrectomy. We don't change. And we start with sleeve gastrectomy. Ideal sleeve is very important because if you have good sleeve, you had good power to push the undigested food to the gastroileum, because you know when the antrum is contracting, this will decrease the gastroileal anastomosis, the diameter, and decreasing the amount of the food. So you need powerful, you need high pressure in the sleeve to push the food. The ideal operation, it is the most first step in gastric bypass, SASI bypass, and nowadays the name is changed to SASI bipartition. Now we detect the ileocecal valve and we count. This is the cecum and the body fat and the ileum. We count from the Tarek and we make highlight on our grasper and take care. For me, almost always I fix it to the antrum. This will help us because I noticed in the cases when I didn't fix it to the antrum, this will make easy operation to make stapler from the left side. At the same time, you know, if you have more traction by gravity, this will make some stricture in gastroileal anastomosis, and in long run will decrease the size and sometimes are closed. So easy, you go by endoscopy and make dilatation of this opening. And also, if you notice that the patient have a wide diameter of the your anastomosis, also you can go by endoscopy and put clip to decrease the gastroileal opening. It is very important to be adherent to the length and the size of the gastroileal anastomosis. It is easy operation. Any laparoscopic surgeon can do this operation in ease with less learning curve. And the advantage of this operation also, it is easy exit. If your patient asks you at any time to come back to the normal, I don't like this operation, I need to go to the normal again. You'll go inside in 10 minutes and you will cut between the two, between the ileum and stomach by your stapler, and you'll convert your normal to the normal as the patient have just a sleeve gastrectomy. If you do gastrography post-operative and you see the two ways for gastrography, you have success operation. But if you see one limb only, you must go inside again and decrease your gastroileal anastomosis, or go by endoscopy and put the visc clip to decrease the size of the gastroileal anastomosis. You must see this two loop, one from the duodenum and one from the ileum. Okay, I'm ready for any question.
Sir, really? So you demonstrate excellent, in my opinion. Everything was clear, and so you demonstrate, especially technical points. That is the most important, in my opinion, especially for our youngsters who are just now following SASI operation. And as Professor has mentioned, so this surgery is need less learning curve, but you must be aware about some technical point that highlighted by Professor. Sir, now we will talk about some post-op. So have you any data so about your diabetic patient that you did surgery and which percentage now is complete remission?
Yeah, as mentioned before, the C-peptide almost it is our light to detect which patient. I can tell the patient before operation, you are going for complete resolution about 100% if I have C-peptide more than 3. If I have C-peptide more 3, I can tell my patient 100% you have resolution if your diabetes. Between 1 to 3, I can tell him around 70% you have complete resolution of your diabetes. If less than 1, between 1.5, it is around 20%. I can tell the patient. Selection of the patient is very important. I told you, you must correlate the duration of diabetes. This is very important to know what is the result of your operation. So the C-peptide is the cornerstone to tell your patient in spite of the duration of diabetes.
Sir, my question regarding now, I think more than about 1 decade you are practicing this metabolic surgery. So definitely your figure is in tetra figure for diabetic surgery. So what is my question? Definitely you are also following your patients. So have you any data about your patient? So now you did surgery 5 years ago, but still a patient is not diabetic. So what is this percentage? 60% are okay, 70, 50.
No, we have 5-year follow-up of our patient nowadays, and we divide our patient according to the C-peptide and duration of diabetes. We have 3 groups, C-peptide more than 3 and duration of diabetes. We have sometimes C-peptide more 3 and duration of diabetes more than 5 years. Duration of diabetes will help us to inform pre-op our patient about the percent of resolution, but usually the C-peptide is the cornerstone. So we can divide our patient to the patient with pre-op C-peptide more than 3 and pre-op C-peptide between 3 and 1 and 3 and between half and 1. Patient usually with C-peptide who is recurrent after 5 years, the patient with C-peptide between half and 1. But no, all patients with C-peptide more than 3 or between 1 and 3, you don't have recurrence after 5 years. But we have patients with C-peptide less than 1 and they have resolution of diabetes, but after 3 years, between 3 and 4 years, you have recurrent again of diabetes. Actually, this is not related to weight regain, but I think this is related to the mass of the islet cell. This is very important, the amount of the mass of the islet cell. Because, still we have a lot of secrets in development of diabetes. We know this is insulin resistant, but what is the factor? It is controlling this insulin resistance, especially expression of the receptors, also the uptake of glucose through the muscle, and what's about of night formation of sugar by the liver. This is we have a lot of secret. We don't have any answer for all of these questions still now.
Sir, excellent, excellent, sir. Sir, you have mentioned, so because as you know better than me, this GLP-1, so one of the effect of GLP-1 on beta cell is hypertrophy of beta cell. And definite, then there will be increase of C-peptide. Are you follow this C-peptide in your diabetic patient, just imagine the patient before surgery was C-peptide 2. Now after 1 year, after 2 years, it become 2.5 or 3. Have you any data?
Yeah, usually we don't follow the C-peptide because you know it is expensive to follow every year about C-peptide to do for your patient, but usually we do it in the first year. Usually we don't have a lot of increase of C-peptide. We are follow the glycolated hemoglobin HbA1c.
HbA1c, yes.
And I will surprise you. For cystic bypass, we have our patient with complete remission is decreasing HbA1c up to 5.1 and 5 and 4.9. And you know, if you have a patient with HbA1c between 5.7 and 6, this is controlled diabetes, but
Yeah.
still you
Yeah.
didn't control the microvascular problem. Because if you're going to control the microvascular problem, you must make HbA1c less than 5.7. And if you like to guard against the microvascular complication of diabetes, you must make the HbA1c less than 5.7. This is the advantage of bipartition. The bipartition decreasing the HbA1c less than 5.5. I have a patient with 5 years with HbA1c ranging from 4.9 to 5.1, a lot of patients. And this is the advantage of bipartition more than the gastric bypass and mini gastric bypass and even duodenal switch, because you have two routes. You don't, we like the duodenal hormones because the duodenal hormones make balance with GLP-1 and BWY. And this will help us to make a balance. We need balance. We don't like to make GLP-1 and BWY more than the GIP. This is very important. This is a cornerstone to treat diabetes.
Yeah, of course. So yeah, yes, sir. Yeah, as you have mentioned, when we will do SASI, and then food will come also from duodenum, because there is also incretins, that incretin secretion from duodenum. When we exclude this, that is the foregut theory. When we exclude that area, so definite that incretins that are anti-insulin, that will be decompressed. So, but when we will do SASI, definite these food will also come from duodenum, and also some nutrient will go directly to ileum. So yes, your procedure so is in favor of hind gut theory, that is the rise of GLP-1. Am I correct, sir?
Yes, you're right. This is my point. Because we need the incretin from the duodenum. We need GIP. And at the same time, we'll make GLP-1 to be secreted at the same time. Because you know, in gastric bypass and the mini gastric bypass, you make a complete exclusion for the duodenum. So the food he didn't pass to the duodenum. So no secretion from the duodenum. And all the secretion will start from the lower, from the ileum. For this reason, you have a lot of GLP-1 BWY, and we have less incretin GIP. For this reason, you will burn the pancreas. But if you have balance between, we need GIP, we like incretin, and at the same time, will stimulate GLP-1 to be secreted at the same time. This will make balance. For this reason, we protect the pancreas from burning, because if you have high GLP-1 and BWY from the start, almost always secretion of the insulin almost always stimulates the pancreas. You will burn your pancreas in 4 and 5 years. But in bipartition, we have a balance between two, because we like incretin at the same time. Because if the incretin it didn't have any function, will never will bring the duodenum to secrete it. This is the normal. We need normal physiology. We'll make balance only, but we need the normal physiology. We need secretion from the upper and lower, but we'll make balance between two.
Sir, are you think so? Due to this, we never face nisidoblastosis in SASI, but maybe like mini gastric bypass or anastomosis. So due to hypertrophy, due to persistence rise of GLP-1, and also impact of this GLP-1 on beta cell and hypertrophy, we will face sometime nisidoblastosis in mini gastric bypass or in duodenal switch or inside, but in SASI, so
No, well, you're right. You're right. Well, this is the problem of continuous stimulation without secretion of incretin. If you have one secreted only, almost always stimulate the pancreas to secrete, to hypertrophy and secrete insulin, and you didn't have the other one, the incretin, which make balance between two. But in bipartition, we push the food in two way, in duodenum and the ileum at the same time. So we need incretin, and almost always we need the GLP-1 BYY. We need to change the timing. We need at the same time. So the same time will make balance between two.
sir, another question regarding micronutrient deficiency, definite when we'll exclude this proximal small bowel, we will face some like iron deficiency, calcium. So what is your data in SASI procedure?
Yes, this is very, very, very nice question. We must know all bariatric and metabolic surgery we are going to disturb the gastrointestinal tract. So we have benefit in one hand and you have complication on one hand. We are going to disturb the anatomy of gastrointestinal tract. So all patients are exposed to any type of metabolic surgery. We have some nutritional deficiency. But when you are comparing different types of the operation, you will compare in what extent you have micronutrient deficiency and how to control it. Is controllable or not. This is very important because you know in Scabinaro you give your patient a lot of vitamin, a lot of minerals, and you can control it. This is a problem. So we must accept that all types of operation had some nutritional deficiency. In what extent we can discuss together. For SASI, theoretical, it is less than the type of mini gastric bypass or Roux-en-Y gastric bypass because you have two routes for foods, one to the duodenum and the other from the ileum. But practical, it is not the same at all because you know you are going to disturb and the anatomy are disturbed. And we don't have a lot about the mechanisms of all of this operation. Even gastric bypass since 1965 till now, if you ask anyone what is the mechanism of gastric bypass to control diabetes or to decrease the weight, nobody can know. We have a lot of secrets still we can't explain of it. And even this is new operation also, we have a lot of secret in it and we didn't answer all the questions. So we have some nutritional, yes, I have some nutritional deficiency, not to long extent, but I have iron deficiency anemia, I have some hypoproteinemia, but controllable. If my patient follow my instruction in diet, he will never exposed to any deficiency. But I remember I'm ex-fan for mini gastric bypass. I'm starting mini gastric bypass 2011. I have a lot of cases. And I used all lenses from the trades ligament from 3 meter, 2 meter. And nowadays I am adherent to 1 meter and 50 only as my recommendation of Robert Ritledge about this. Don't exceed 1 meter and 50 for mini gastric bypass because I saw a lot of patients. When I make the limb more than 2 meters, this will make a lot of nutrition deficiency. I lost 3 patients from liver cell failure with mini gastric bypass because severe nutritional deficiency and I can't control. I give the patient large amount of protein, large amount of vitamin, but I can't control the nutrition deficiency. So we have complication. Yes, we have nutritional complication, but it is controllable. If you give my patient, ask him to eat protein 70% in each diet, he gives a vitamin and the iron, This will control everything. But if you didn't take it, you're exposed to severe hypoproteinemia and severe nutritional deficiency and vitamin deficiency. But we have many operations. In spite of vitamins, in spite of protein, you can't control it. And this is how to compare between the operations. This is very important.
Sir, excellent. Sir, in SASI, definitely we have a wide sleeve that is not tight sleeve. And definitely we will have a acid production as compared to so other procedure. Definitely there will be more acid production. Have you faced marginal ulcer in your cases?
Yes, usually I have any one anastomosis, you have marginal ulcer, but you can guard against it by some tricks in your anastomosis. This is very important. If you make your anastomosis hand sewing, this we have less marginal ulcer. If you make your anastomosis not tight for ischemia, you have less marginal ulcer. Usually the marginal ulcer is not related to acid reflux or related to technical, to Stabler. So nowadays I do hand sewing for my anastomosis with Vicryl. This is very important and not tight, no ischemia. To my anastomosis, I have less marginal ulcer. But any one anastomosis, you must have marginal ulcer. You can treat it so easy. And there is some adaptation. After 1 year, there is adaptation of the new gastrointestinal tract. So the percentage of marginal ulcer is decreasing.
Sir, one of the reason of marginal ulcer is smoking. So what is your protocol for a smoker? So same like mini gastric bypass and other surgeons, they have concern in smokers and Roux and why. So what is your protocol?
Any type of bypass, Roux-en-Y gastric bypass, mini gastric bypass, any gastric ileal anastomosis, you must tell your patient you must stop smoking. Yes. Because this will increase the marginal ulcer 100%. Any type of gastrointestinal anastomosis, you must tell your patient you must stop, because not the problem of the marginal ulcer, the problem, a percent of perforation of the marginal ulcer is more with the smoker. This is the problem.
Sir, definitely now, because so much thanks, our time is also a little over, and I know this is the late time, and just I am interested to hear from your side after this, how many surgeries you did and this data and follow up. What is your main concern after SASI?
Main concern as regards
complication. So always you
complication.
Think, yes.
No, I will tell you something. If you are going to make any gastroileal anastomosis or any gastrointestinal anastomosis, there is a message must be almost always addressed to your patient. You are going to disturb your gastrointestinal tract, so you must follow our instruction. You must have high protein diet and you must be adherent to the multivitamin. This is our message. If you follow my instruction, you will never have any complication. This is a problem for our patient. You know, the compliance, especially in our area, the compliance, adherence for a patient is not good. For this reason, we will prepare our patient pre-op with many tool of education and many session. And sometimes I make the consent, video consent, because he must remember that I told him before operation, if you didn't follow my instruction as regards the diet post-operative, especially high protein and multivitamin, you will face a lot of problem. So if you follow my instruction, welcome, I will do the operation for you. If you don't feel that you can follow my instruction, please don't go any operation, because we are going to improve the quality of life of our patient, not to induce another disease for our patient. So if your patient is not adherent for your instruction, believe me, don't accept to do any operation for him, and tell him, I will induce another disease for you if you don't follow my instructions.
Sir, so much. Sir, just with all respect to this technique, and especially SASI, because personally also I am doing, not like you, so limited cases we are also doing. So one of the always concern and talk about this bile rotation. So some of surgeons they ask, the bile will go again in duodenum and again in duodenum, and I don't know. Oh, can we measure so like this? So is it correct? And if it will happen, so what will be?
What you mean again in duodenum, again in duodenum?
So when bile, because this is a loop, okay, this is the loop. Okay, when bile will come to this gastroileostomy, so maybe again this bile will go again to duodenum from pylorus. Is it
Yeah,
possible?
yeah. Really, we must go to analyze in the on scientific way. You know, the antrum is able to receive bile in normal person, and the same time in sleep, even sleep gastrectomy. When you are doing endoscopy for our sleep gastrectomy, after sleep gastrectomy, we find bile in the antrum. This is normal. The problem, bile in the esophagus. This is a big problem, and you must convert the patient direct to the normal, because bile in esophagus mean adenocarcinoma. But bile in the stomach, it is easy. It is normal to find the bile in the antrum. For this reason, we are insist to do your anastomosis with the antrum, not with the body, because when you are going to do your anastomosis with body, this means the bile will come near to esophagus. But the bile in the antrum, it is normal, and the antrum is capable to deal with bile in this area. So if you see more bile in the antrum and the pylorus, it is not a big problem, and it completely is not related to the marginal ulcer. Marginal ulcer is related to the technical point, 100%, and smoking and Helicobacter pylori. This is the three factors for the marginal ulcer. But bile in the antrum, it is a normal. But bile in the esophagus, it is a catastrophe. You must convert to the normal because this will develop adenocarcinoma.
Sir, really so much thanks. And it was really one of the best session in my opinion, especially your that demonstration, your technique, your video, that was really amazing. Sir, because now we have also a lot of viewers, and also I can see some question. So Dr. Mahmoud Basho, so already Professor explain about advantage of SASI and over MGB, and you can also see that was amazing. Sir, we are also interested to hear your message for our youngsters who are just now going to start SASI or metabolic surgery.
For young surgeons starting metabolic surgery, I think first you must select your patient. You put your mind that you are going to improve the quality of life of your patient to induce and not to induce another disease. So good selection of operation, individual selection is very important. You have a lot of tools in your hand. You have sleeve gastrectomy, you have SASI bypass, you have mini gastric bypass, you have Roux-en-Y gastric bypass. We use all. I do all of this operation. But when you are going to do mini gastric bypass, please don't exceed 1 meter and 50. This is very important. Sometimes your patient asking, and this is the right of your patient to select the operation. If you are going to Roux-en-Y gastric bypass, you can increase, because you know the classic Roux-en-Y gastric bypass durability is less. So the long BBL is good with less complication nowadays. I have a lot of patients with long BBL with Roux-en-Y gastric bypass. I have a good results. Roux-en-Y gastric bypass is still the golden operation because we have a lot of research about it. So still up to this moment, the Roux-en-Y gastric bypass, طبعا new edition for Roux-en-Y gastric bypass, it is still the golden operation. SASI bypass, it is golden operation, but still we don't have a lot of research about here, so we encourage a lot of surgeons to do it. If you like to do mini gastric bypass, please, my message, please don't exceed 1 meter and 50, because I have a good experience with mini gastric bypass. I have a lot of patients, and I use all the lenses from 3 meter, 2.5, 2 meter, even 190. Please don't exceed than 1 meter and 50. I follow my patient for more than 7 years. I saw all complications after mini gastric bypass. Mini gastric bypass is good operation, but take care 1 meter and 50, you will less nutritional deficiency, and it is good operation also for diabetes. For SASI bypass, it is good operation. For me, if you ask me, if you have a patient with diabetes, I'm going direct to if SASI bypass, if the patient accepts. If the patient didn't accept, I go to Row-NY with long BBL. If he didn't accept, I'll go to mini gastric bypass. If the patient has diabetes less than 5 years and didn't have reflux esophagitis, I offer for him just a sleeve gastrectomy because I have another tool in my hand if the patient have recurrent of diabetes after that. But still, sleeve gastrectomy, it is the more physiological operation. For this reason, also SASI bypass is more physiological because he follows the rules of sleeve gastrectomy. We have two routes of ways for food to go direct to the normal DRAM and to the ileum to induce the metabolic response.
Sir, so much thanks. So much thanks. And thanks, my viewers, that till this time, especially in India, now late time, and also in this Middle East. So much thanks for your follow-up. And this all activities and this interview series is due to your interest. So next week, Tuesday, again at 10 p.m., we will be with another expert of metabolic surgery in low BMI. Sir, again, so much thanks, and we need your support and guidance.
Thank you. Thank you.
Thank you, sir. Have a nice time, sir.
Thank you. Have a nice day. Thank you.
Thanks.